Thank you so much, Rafi. It's an honor and a privilege to be invited to present in this course alongside my esteemed colleagues, mentors, and teachers from the past. So this this presentation is titled, in case you missed it, it should be subtitled The Cure for FOMO, Fear of Missing Out. And in case you fear of having missed on something, then this is likely to be a little bit of an antidote for FOMO, but we'll see. So it will be thanks to the overlapping pandemics that are upon us, will be a mismatch of things that have just come out on monkeypox, on COVID, but also, of course, on HIV. And here are my disclosures. So, and our objectives, we hope at the end of the next 30 minutes that you'll be able to describe the clinical presentation of monkeypox infection and what is new about that, outline new findings on complications of antiretroviral therapy. There will be a presentation on treatments and new drugs, so we will focus on complications, and then describe new data on the management of co-infections and opportunistic infections, as well as discuss key findings on COVID prevention in HIV. Some of those developments are as of 3 days ago. So, and here's the outline: monkeypox first, then non-AIDS complications in the cure agenda on what has transpired in the past month, opportunistic infections focusing on hepatitis B and PrEP and PEP, and then finish up with COVID, efficacy of testing, and the new data on vaccines. So here is the monkeypox. What we would like to outline is that it's not what we thought it was. So we have known this disease for decades, and the new epidemic that popped up in May of this year had features that we did not appreciate or were not as familiar with. And this is what we know through a number of publications that have come out in the past couple of months. And the next few slides will be a little wordy, and this is, I apologize for that. This is for a reason. We need to outline what you're likely to see in a person suspected of having monkeypox and what is different from what we thought we knew about this. The first one came from a New England Journal of Medicine publication a couple of months ago from 500 plus patients across 16 countries. And this is what they had seen. 98% gay bisexual men who have sex with men, 41% of them were living with HIV. This data has almost been verbatim duplicated in the US. And what I'd like to highlight on those people living with HIV is that they were by and large virologically suppressed with its relatively high CD4 count. So you don't always you don't only suspect this in somebody who has advanced disease, even if it's likely that they will have a higher likelihood of adverse outcomes from the infection. So the clinical presentation also a little different from what we had seen in the past, in that most people actually have very few lesions. So you don't think smallpox that has covered the whole body and the centrifugal distribution, but most people have a very small number of lesions, and focusing probably on areas where there was direct skin-to-skin contact in the genital area. So 71%, 3/4 had genital lesions. So seeing people with rectal bleeding or discharge is common in this disease. And more importantly, concomitant sexually transmitted infections are very common, up to a third of people in most cohorts. So 3 people experience serious complications. So this is not COVID. That is not as lethal an infection as COVID has been, fortunately. And so again, what is also been appreciated in this study from a couple of weeks ago in, in France is that we can actually have a certain number of asymptomatic infections. And how do we know that? These people had a sexual health clinic in Paris, and they decided to do anal swabs routinely for STI surveillance. And those who were negative for chlamydia and gonorrhea, they were tested for monkeypox. And this is what they found. I apologize, this is a little too small for you to be able to read, but you will see on the column on the right that a good number of those who had symptoms suggesting monkeypox indeed had monkeypox. And among those who did not have symptoms of monkeypox, 200 of them, 13 actually did test positive for monkeypox. And 13, and some of these actually later on develop symptoms of monkeypox. Now, what does that tell us? Either that asymptomatic infections are common, or pre-symptomatic presentations are silent in a number of, and that some people would present without symptoms if they had a contact. So it's important to highlight this because you will likely see people who have risk factors or indeed might have had an exposure as of late. They actually might be infected when you see them. And during the current outbreak, as the CDC reacted to the data I just presented by issuing this, that lesions often occur in the genital and anorectal areas and the mouth. They could be few, and they may not involve the palms and the soles, and rectal symptoms are common, and fever and other prodromal symptoms such as chills, lymphadenopathy, malaise, myalgia could occur actually after the rash has already presented. So they're not necessarily prodromal as the name implies. And then respiratory symptoms can also occur. So it's important to raise awareness if you see people who meet the definitions for at-risk populations that this could happen. Again, 40 to 50% in many cohorts of people diagnosed with monkeypox are living with HIV. So it's important for us to know what, if any, should be different in managing monkeypox in people who are living with HIV. Number one, there was, it's not necessary that you have an advanced HIV to have monkeypox, but you might be at a higher risk for for severe disease or severe manifestation for monkeypox. Post-exposure prophylaxis and antiviral treatments are available for people exposed with monkeypox, and we really unfortunately haven't learned a whole lot from the COVID pandemic because we still are suffering through the same things, slow rolling out of testing and slow availability of preventive interventions. So this is exactly what we're facing here. However, tecovirimat may result in a reduction in levels of some HIV medications in the class of the NNRTIs. This had caused some consternation in the past, and the Liverpool HIV Interaction Committee, have flagged that. But as of late, it's possible that reduction is not significant enough for you to alter the treatment of somebody who's on an NNRTI. Safe carbotegral ripivirine, it's now recommended to not initiate it during tecovirimat treatment. The vaccine, Jynneos, the modified vaccine Ankara, it does work, it's safe in people with HIV, and I will show you later that we still do not know how well it works, HIV or no HIV, and the ACAM 2000 should not be given regardless of the immune status. So this is monkeypox with or without HIV. Now, this is as of 3 days ago or 4. We know already that people like me were born way before 1974, are faring pretty well with this because we do have a certain level of immunity. So this is a reduction neutralization test looking at people born before 1974 in the Netherlands and those born after 1974. You see the red dots and triangles that if you're born before 74, you are likely to have a certain degree of immune protection against monkeypox. Now, if you are born before 74, whether you have, if you already have monkeypox, you also will develop some antibody response to it, whether you're born before or after, and it doesn't make a difference whether you're born before or after. So two ways in this study that they may find monkeypox antibodies in you is you were born before 1974 or you have had monkeypox. Now, what happens if you actually got the vaccine? You will see on the left, if you were born before 1974, it doesn't really matter as much, according to this study. Now we'll see what happens in other cohorts, is that the level of antibodies you had did not increase a whole lot. There are 4 groups of triangles or dots there on the left. The first group is pre-vaccination. The second group is 2 weeks after the first vaccine. The third group is 4 weeks after the first vaccine, and the fourth group of dots is 4 weeks after the second vaccine. So that boosting of the second vaccine given 28 days or later did not seem to do a whole lot for the rest of us born before 1974. But if you look at those born after 1974, of course, like I showed you in the first diagram on the left, is that they did not have antibodies before the vaccine. That's normal, but they did not fare a whole lot better after the first shot or 4 weeks after the first shot. After the second shot, 4 weeks later, they had some, but it wasn't great. It wasn't actually to the level of those who did not have vaccine but were born before 1974. So this study suddenly calls into question the efficacy of the monkeypox vaccine that we have been using. What I'm not going to present to you is that it called into further question the strategy of the intradermal administration of a fifth of the dose, even if the technique is different and the formulations are different. We have to be careful about the data that these recommendations stand on. So now let's move on to HIV. First, introducing PrEP and PEP by looking at who are we prepping and pepping. The people who are the most affected by this epidemic, especially in the US. Blacks, African Americans, Hispanics, Latino, and white. So you can see the diagram here. Now, what happens is that PrEP penetrance is still really poor, and there are still significant inequities in that penetrance. If you live in the South, like I do, you know that this is where the bulk of the epidemic is, and especially in the vulnerable populations. And this is where we don't see a whole lot of PrEP. And the green line, which takes off from the other ones, the whites, and they're getting the most PrEP, and we don't see a whole lot of PrEP even in 2021 in the other racial and ethnic groups. So we have a significant inequity problem that we need to fix. Correct. Now, if you do have people on PrEP, there are significant proportion of them who would present with sexually transmitted infections. This is somewhat mitigated by the guidelines of screening, even asymptomatic ones. But what this diagram shows you for context is that that screening is not, it doesn't address the problem adequately. There's still 25% of people out there on PrEP who have at least one STI. Now, what can you do about these people. Thankfully, it looks like you could do something. And this is called DoxyPEP. And DoxyPEP is this study in men who have sex with men and transgender women with HIV or on PrEP. Had an STI in the past year. So the people, the 25% I just presented to you in the previous slide, they were randomized 2-to-1 to receive 200 milligrams of doxycycline within 72 hours of a condom-less sex, or no doxycycline with STI treatment and at enrollment quarterly and when symptomatic. Now, on the right, unfortunately, it does not show well. I apologize. But what I'm going to read to you what's on that table, but I can't see, so I'm going to put my glasses on. So what's on that table is the risk reduction in STI incidence per quarter. That's the top table. And then on DoxyPEP reduced STI to a third of what they were before. So it's really an incredibly positive study. And that was, people made a lot out of the differences in the risk reduction between those on PrEP and those live with HIV, but I really don't see much of a difference when I look at these numbers. They're about the same. And then on the left, the table shows you the numbers, and those with primary STI endpoints when they were not on doxy were about a third, about 30%, right? A little under 30% without living with HIV or on PrEP. And with DoxyPEP, it was less than, was 9.6% for the those on PrEP and 12% in those living with HIV. So this is a very positive development that I would hope will be replicated and will be followed. I think this is a relatively simple intervention and a cheap one, but unfortunately in the United States, we don't like cheap interventions. If it was expensive, I would be very hopeful that it would be used. So here's our unmet needs on opportunistic infections. We have to look at this study. And cryptomeningitis, I was talking to Dr. Sag last night, is something that is incredible. If you live in sub-Saharan Africa, you really do not want to have cryptomeningitis because it will kill you. And it's not as deadly here. So it's important to look at what you could do to mitigate such a lethality. And in South Africa and other countries, they have started looking at screening for serum cryptoantigen in people who do not have symptoms of meningitis. And this is one study where they looked at people were during that screening, 95 screen subject compared to 32 on-screen subject received fluconazole prior to their being diagnosed with cryptomeningitis. So when they screened positive, they got fluconazole, and what happened is that they died less from the disease, and the disease was less severe, lower CSP opening pressure in those who were screened and given fluconazole. So what this shows is that serum cryptoantigen screening is likely detecting cryptomeningitis at an earlier stage. That is at a pre-symptomatic or post-symptomatic state. So this is what the DHHS guidelines have for now. Serum cryptoantigen screening in those who still count on less than 100, and in screen positive patients, CSF evaluation should be performed. So now let's move on to another OI, another co-infection of HIV, which is hepatitis B. About 5% of people in the United States, and on Sub-Saharan Africa, Southeast Asia, hepatitis B co-infection is a lot higher. And this one study is in Asia. And what they did is they looked at bictegravir FTC TAF versus dolutegravir plus FTC TDF. Of course, FTC TAF and FTC TDF are the ones that are likely to be active against hepatitis B. And in that comparison, both performed equally well in reducing HIV viral load, and that was no surprise. But the surprise was that bictegravir FTC TAF had a better efficacy against hepatitis B On the right, you see the proportion of those who were virologically suppressed for the HIV is the same on top, and the bottom of the hepatitis B is different in better with TAF-FTC. And on the table on the left, you see that other outcomes were better. ALT normalization, antigen, S antigen and E antigen loss were all better with TAF-FTC. I would really like to see what others would think about this and whether it will be duplicated, because this is not something that was seen when TAF-FTC was being tried in people with hepatitis B. Okay, so now near and dear to my heart is comorbidities. We now having people living significantly longer with HIV, that's a good thing, but they are carrying a huge burden of comorbidities, the number of which continues to increase and is expected to be significantly high in the, by 2030, i.e. in 10 years. What we see here is that with antiretroviral therapy that is so effective, we have narrowed the gap in survival between people living with HIV and those who are not. There is still a gap. And what is the remaining gap is comorbidities and non-infectious complications by and large. So how can we reduce them? We thought that we did, and now we had this study presented at CROI a few months ago that between, this is Partners of Health in Massachusetts and Casa Permanente in California here, is that from 2005, 2009, there was no difference in incidence of acute myocardial infarctions in people with HIV and without. Good news. On the right, 2010, 2017, those curves are diverging with more acute MIs in people with HIV than not. Not good news. And why would that be? We're having safer drugs, more metabolically safe drugs, but we need to understand what this means and increase our vigilance for that. So when we had the START trial, we showed that, it showed that if you start HIV treatment early without letting the CD4 count drop, you not only decrease the incidence of infectious complications, but also non-infectious complications. That was very important and shouldn't be overlooked. But what about people who have controlled the virus themselves without the drug? Do they still have a high risk of complications? It's possible that it was possible that they didn't, but here this study suggests that they have just about the same rate of non-AIDS defining events as people on suppressive ART. So that will need to be discussed, and what does that mean? Should we still pushing for these people to be treated? But the cross-sectional imaging suggests that they actually have more coronary calcifications than those who are on suppressive ART. Now, this is a trip down memory lane. About 12 or 13 years ago, we found out that if you start treatment with abacavir, within the first 6 months, your rate of MI was higher than those who were not starting abacavir. This came to us thanks to the DAD cohort, and that got a lot of people scratching their heads. If you think you've seen this before, you are seeing it again. Now, what we see with the RESPOND cohort is that it's showing us that instances where use was associated with increased risk of cardiovascular disease within the 6 months after the onset, which is eerily reminiscent, in my view, of what we had seen with abacavir. And of course, we need to understand this. Now, I've seen people divided into two camps, the believers and the non-believers. But when I joined science, I thought it was not a religion. We need to just understand whether this is important or whether this is true or not with more studies. Again, other studies suggesting that the weight gain that we've seen with TAF and INSTIs was actually associated with de novo steatohepatitis in this particular study. So things to keep an eye on. But this is not something that has been universally seen. And reprieve, which is a gift that we'll keep giving, has already given us that we probably do not have a higher risk of metabolic syndrome with INSTI. But on the right, at the IAS World AIDS meeting last month, we had another study suggesting that MI, congestive heart failure, and lipid disorders were more common in INSTI users. So a hotly debated issue that we need to get more clarity on. Now, let's go on to cure. We are probably making strides, but this study, I'm going to summarize it very briefly, is VRC01 suggesting that it was safe in infants, but not efficacious in reducing the HIV RNA. Now, the plasma viral levels were lower than was predicted. So it's important to see if this is an intervention that may need to be optimized, combined with others, and to get a better efficacy. Again, this is highlighted by the fact that post-hoc analysis showed that higher VRC01 concentrations correlated with larger reductions in HIV DNA from week 04 in this study. So again, we keep getting a trickle of people who actually got a durable remission, I should call it. This is a prolonged HIV remission without antiretroviral therapy in another allogeneic stem cell transplant. I like the name City of Hope patient, because this is really our hope that we'll get there soon. And that is the cure agenda marches on. I think that there will be a lot of progress being made. Now, let's close on with COVID. And I was asked to take COVID antigen test to get here to be allowed to talk to you. But how good are they? So this is one study that actually gives a little more of a window. It's that we compared to two things: the PCR test and the the culture. The antigen test, one is not very sensitive. If you do 2 days in a row, you significantly increase the sensitivity. So it may be something that people should try doing. So we had, in the early days of HIV, understood that thanks to some data from South Africa, Western Cape, and then WHO, what is the risk of people living with HIV? This is one study that showed that in-hospital mortality from COVID that's higher in people with HIV, and the risk factors were older age that we knew, but also low CD4 count, chronic kidney disease, and diabetes. So, and this is sort of an advanced HIV disease. So it's important to know that with COVID, the moral of the story is that you should really, really be pushing for vaccination in your people living with HIV. And that vaccination, how good is it? We have seen that there was a resistance to move to a different vaccine formulation with the different waves of the COVID virus, up to Omicron, the father. But Omicron, the daughters and the sons, is not faring so well with, the vaccines are not faring so well with it. This is a CDC study with BA2 and 2.12, already showing in the boxes that the efficacy of the the mRNA vaccines from that were available is a little lower after a couple of doses, and maybe booster was even more important in these people. But then came this study last month in COVID vaccine efficacy during the newer Omicrons, BA4 and BA5. substantially by 4.2-fold more resistance, and thus more likely to lead to vaccine breakthrough infections. And this Omicron BA4 and 5 are branching out here in red. And what they have is specific mutations here, specifically L452R, which is leading to this level of immune escape. So what that tells us is that we need this, and it's already here as of last week, bivalent COVID vaccines. And I have exceeded my time, and you should give them for everyone who is at least 2 months after the initial series. Thank you. Oh, okay.
So if anyone has questions for Roger on any of the data that we've been talking about, please do put it in Slido. While we're waiting for those to come in, and please do think if you have questions that you'd like to pose to Dr. Bedimo. Roger, obviously I was fascinated by the doxy-PEP data at AIDS 2022 this summer. And I was a little surprised to see reductions in gonorrhea incidence. We level resistance to gonorrhea to doxy that I wouldn't have expected it to have efficacy, and indeed in doxy-PEP study that he did to Ipergay, there was chlamydia and syphilis reductions, but not gonorrhea.
Yes.
What do you think?
Yeah, that's very interesting in that actually, if my memory serves me right, there was actually doxy resistance in the gonorrhea that they diagnosed in those who got it. So it's possible that the size that it's not as important to have a higher efficacy against GC. That is all I can say. Maybe a doxy. Yeah, but this is a contrast to that previous study. I agree.
But I mean, the question is, would that be tolerated, right? I mean, we that for Lyme disease sometimes, and I think very exciting, I think. So we have a question from the audience. How would you compare monkeypox data to the original Jynneos approval, which showed high-level antibodies? Is the difference primarily from monkeypox versus smallpox neutralization, or do we not know yet?
Yeah, that's a great question. And that paper from last week in the Netherlands touched on that the techniques and the formulations and the passages that these vaccines have gone through prior to testing may be different. It's very difficult to compare. But if at least one thing, this should be paused, because again, we are using a surrogate action here. Let's be clear. Don't know how good a surrogate that is to begin with. And then the testing differences add another layer of uncertainty. It's just that we should not be so quick to.
And I think it's a very sobering warning, right? Another question from the group. Do you have any hypothesis as to why the TAF-based regimen fared better outcomes than the TDF FTC?
It's puzzling to me. I looked at how would TAF work against HIV? Other sides, I know very little about the liver cell. But it's possible, we know that for TAF, for much have been talked about intracellular versus levels. Now, whether that applies to other sites, I don't know. I think that this will be something that
Have you changed your practice yet in terms of? Of course, CAF FTC doesn't have US regulatory approval.
I don't, yeah, I haven't. And I work with a very changing. It's not up to me.
I think lots more to be said about that. We have a question from Dr. Sag. What do you make of the Lancet study that showed the integrase associated increase in coronary events up to 2 years after initiation? And, should we counseling our patients if we initiate INSTI based about this, or what are you telling people?
Yeah. That gave me echoes of the first thing I looked at is, okay, how do you get a myocardial infarction? It comes from years of eating burgers and building a plaque. And then that plaque becomes unstable and ruptures. So if you take a drug, and if it is, let's say, plausible that that drug led you to have a high risk of MI, that means you did not build that plaque in 6 months. All of us are working with likely occluded coronaries and just wait something to make that plaque. So my hypothesis is that something is making that plaque unstable and rupture. And this is where we need to look. And again, it's become such a charged thing. Just again, like in with Abacavir, that some people say, this is hogwash, don't believe any of this happen. I think we shouldn't get there. We should have the candor of telling people that we don't know. You will read about this, we don't know, and it's that we need to find out. And if it keeps getting reported, then I will be cautious about it. That's all I can say.
Story of these data at this.
Now we're live.
Can everyone hear us okay? Yes.
Yeah.
Excellent. Thank you. So one last question also from Dr. Sag. Can we expect to see clusters of monkeypox cases in contact sports, particularly now that kids are back in school and some of the professional sports teams are beginning their seasons? And if so, how should we mobilize resources to prevent cancellation of seasons?
It's a multi-billion-dollar question, Dr. Sack. And I think that what we've learned from 2022 epidemic is that it takes close contact and respiratory transmission, the fomites, maybe happens, but not whole lot. Now, when is it gonna be herpes gladiatorum that gonna have people getting, it is possible. And what history shows us is that while the disease is in 98% MSMC, it will spill over to other populations. Just that if we have it circulating long enough by our negligence of a lack of enthusiasm in dealing with it where it is now, then we might deal with canceling football season soon.
And that.
But not Alabama.
Well, we're gonna need to move on to our next speaker, but please join me in thanking Dr. Bedimo for a great talk.
Thank you.